Good afternoon. Welcome to 108 Snippets. My name is Richard Sainsbury. I'm a breast surgeon. I've been associated with 108 for about 20 years. When I moved to London in 2000, Jerry Gilmore asked me to join the team, and I've been with them since. The topic I'm talking about today is quite a rare one, but is being recognised increasingly, and it's something I think you should be aware of. I'll give you some advice on what to do if you come across it. So what we're doing today is talking about breast implant associated anaplastic large cell lymphoma, which sounds a right mouthful, but is a specific condition that has recently been described and is associated with our patients with implants. Silicone breast implants, as we now know them, were first used in 1962. But prior to that, there's been a long history of trying to put things into women's breasts to make them bigger. At one time, sponges were used, fat has been used. In the old days, we do use fat now, but in the old days, chunks of fat were cut out and just stuffed in the breast, and paraffin injections were all injected. In the early days, direct injections of silicone started mainly in the sex trade arising out of Japan and China, and then imported to the West. And this became incredibly popular at one stage. And you may remember the Jane Mansfield sweater girls. A lot of them improved their bust by direct injections of silicone. Interestingly, it was only banned by Congress in the United States as late as 2004, though I think it stopped a long time before that in the UK. Implants were withdrawn from the market in the States from '92 and only reintroduced in 2006 because of unfounded fears about silicone leakage, about autoimmune disease. And it almost brought Dow Corning, the company that made silicone, to its knees, but eventually the judges there threw it out as junk science. They were never withdrawn in Europe, and so there's a lot more information in this interim period from Europe and Australia than there is in the States. Currently, it's estimated there are about 8,000 augmentations a year in the UK and about 300,000 in the States. We're not sure how many implants are used for reconstructions. We do have a national implant registry, and we're getting a hand better information from that, but currently the exact information isn't available. Usually an implant's put in to increase volume and appearance, and so this is a typical augmentation for a small-breasted girl who has not underdeveloped breasts, but slightly small breasts, A-cup breasts, who wants to be a B or a C cup. And a satisfactory appearance could be obtained. There's breast fullness and a better shape on top. And that's an ideal candidate for someone who wants an augmentation. Sometimes this is coupled with a mastopexy, where a breast lift is performed, in which case an incision is needed underneath to tighten the skin underneath to lift the breast. But for the younger person, the younger girl, then a straight augmentation is often all that's needed. For a simpler form of reconstruction, an implant can be used. This is a lady who didn't want an abdominal flap. She's got a reasonably ptotic breast here. She's postmenopausal, and all she wanted was some fullness, so she didn't have to wear an implant in her bra. And so we've got a satisfactory appearance for her when she is clothed. She's obviously not symmetrical naked, but this gives a very nice reconstruction and provides a very safe alternative. Now we're increasingly using it with a mesh to cover the implant to reduce the body's reaction to it and to give a better cosmetic result, but that wasn't available when I performed this back in the 80s. There are various types of silicone implants. We have a smooth one, as shown down here, and then we've moved to the textured ones. Initially, it was felt that the biggest side effect from implant insertion, which is a capsular contracture, so the body does not like any foreign body in it, and if it can't expel the foreign body, it forms a capsule around the implant. The trouble is, for something soft like an implant, this capsule will sometimes scar down and contract, and that produces an unnatural appearance. And that's where the term double bubble came from, where a patient had their implant stuck on top of their normal breast and looked quite unattractive. And we initially thought back in the 80s that if we could make the implant as smooth as possible, then you wouldn't have the problem with capsular contracture. Actually, that turned out to be completely counterintuitive. It was only when textured implants began to be used that the incidence of capsular contracture dropped right away. So there was a wholesale move to textured implants. Now the texturing is made by taking the shell. Here is, this is actually in the factory where they make them. This chap's topping up the silicone in the back of the fill port. But basically you have an empty outer shell and you stretch that over a mandrel, and then you fire salt crystals at it. So you start with a smooth implant and you fire salt at high velocity, and that textures it. And depending on the grain size of the salt and the velocity, you'll get different texturings. And so up here we've got different shaped implants, we've got a round implant, teardrop implants, and here we've got, these are textured, but this has a different texturing to this one. And then there are polyurethane implants where the actual fill material is a polyurethane foam. When an implant's manufactured, it's then filled with silicone, and a technician injects, makes sure there are no air bubbles, and then injects the final drop of silicone before this being sealed. And this is the Mentor factory in the Netherlands. The subject we're talking about today is this thing called BIA, which is breast implant associated large cell anaplastic large cell lymphoma. This was first described as a condition as recently as '97, but only classified as a lymphoma by the World Health Organization in 2016. It's important to note this isn't a breast cancer. This is a lymphoma, a separate lineage than any of the epithelial cancers. It's an indolent T-cell lymphoma, and it's only associated with textured surface breast implants. It's not been found in patients who've had smooth implants. And there appears to be no difference if you're using the implant either for an augmentation or a reconstruction, but because the augmentation is much commoner, there have been more reported cases in patients who've had augmentation. The estimates vary depending where you are in the world, which may reflect local practice, may reflect on registration, and may reflect on the type of implants used. But they vary from 1 in 1,000 implants to 1 in 30,000 implants. Our MHRA estimates the UK incidence is 1 in 20,000 implants sold. So not common, but getting out there. There have been 780 cases worldwide as of November 2020, with 78 in the UK, 17 deaths worldwide, of which only 3 proven due to the lymphoma. The others were possibly related to breast cancer or other conditions. So they had to be quite strict criteria to be proven to be the lymphoma. And only 1 of those has occurred in the UK. There have been 2 other deaths in the UK, 1 of recurrent breast cancer and 1 unknown. The cause is hugely debated. No one quite knows why this condition arises. It was the word biofilm encompasses a biological film that surrounds an implant which may have bacteria associated with it and was thought to cause the early rejection of implants. But since we've reduced biofilms by soaking the implants in betadine or similar compounds, that should be cause lower incidence of biofilms. It certainly cause lower rejection and lower capsulation rates. So why it should cause more problem is unknown. Another theory is there's an allergic profile of cytokines found, and that some patients genuinely are allergic to implants. And in other cases, shedding of silicon particles has been detected, which we know does happen from the outer shell, and those are, some people propose are immunogenic. and there does appear to be a slight genetic predisposition. The diagnostic criteria has to be that the cells have to be positive for the marker CD30 and negative for ALK, which stands for anaplastic lymphoma kinase, when you stain immunohistologically. So patients present usually as a swelling around the implant, often many years after insertion. We're talking 8-9 years later. So this delayed seroma is associated with about 80% of these cases. But if a patient presents to you with a delayed seroma, only 10% of these are due to ALCL. So 90% are due to low-grade infection or other causes. And so whilst it's important we see these people and investigate them, the majority of delayed seromas are not caused by ALCL. 40% have a mass associated with them, 8% capsular contracture, and in 2% they present as a rash. So we do an ultrasound scan, we aspirate any fluid and we stain it with the CD30 plus marker, and I'll show you a picture of some cells. And then we go on to do a PET CT to look for any metastatic disease and an MRI for local assessment. So here's an ultrasound scan, here's the edge of the implant, here's the fluid, and in this case you can see collections of cells here floating free in the fluid. These do not respond to Doppler, so they're not vascular. And here on the MRI scan you can see indentations. These, and here a growth in the wall, and here another growth in the wall of the capsule. So those are fairly typical. Under straight staining, you may see cells undergoing mitosis as here, but with the CD30 stain, you see these very positive CD30 pickups, which is diagnostic. What we do is we remove the capsule. Here's the implant. Here's the capsule removed whole, and we replace the implant with a smooth implant, or consider some other form of reconstruction, like using autologous tissue, losing the abdomen or the back, or a flap from elsewhere. We don't need to biopsy the nodes, as this is a lymphoma, but if the nodes are enlarged, an ultrasound scanning will do so. And the very few rare cases where the metastatic disease go on to have chemotherapy, and there is one of the monoclonal antibodies, rituximab, which is specific for this condition, and that's used for advanced metastatic disease. I've seen 2 cases now, which puts me up there as an expert, not, but it is very rare indeed. So what to do? Going forward, we now must give informed consent of every patient having an implant put in for whatever reason about the risks of ALCL. Patients who had Allergan implants with their textured surface, their BioCell implants, need a little careful consideration. Allergan withdrew the implants in 2018 when it became clear they had the lion's share of these conditions, probably related to the size of the texturing on their implants. Currently, the MHRA recommends that there's no need to notify patients with an implant, although I have to say that if I do see a girl for a consultation who has implants, I make sure they're aware about a delayed seroma. I think that's only responsible of me as a so-called expert to tell them this, but for you as an individual GP, I don't think you need to be worrying your patients, every patient with an implant, that this remote risk exists. Patients with textured implants will continue to be used. Textured implants will continue to be used because of the lower capsular contracture rate, and they're much better for the shaped implants. If we see cases, they have to go on the yellow card scheme, and we've got the National Breast Implant Registry, so we inform them. The MHRA have issued 3 MDAs in 2011, 2014, 2018, updated last year in 2020. There's ongoing research and advisory boards, and there's a plastic and reconstructive aesthetic surgery expert advisory group, of which the vice chair is our own Fiona McNeil from 108, who sits on this committee. And out there, interestingly, the lawyers are beginning to sniff around this, and a class action is being considered. So what do you need to do? So my advice is, depends what the patient's consulted you for. If there's a problem with breast implants or a breast complaint, you must check there's been no seroma development, and if there has, send them in as soon as possible. Ask the patient if she knows which implant she had. She should have a card with the details on, but many don't or have lost it. You can refer them to advice, either back to the operating clinic, but you'll always have problems with places like Transform, Harley Medical, etc., as they regularly declare themselves bankrupt and then reinvent themselves, and the records may not be available, or we're very happy to see them here. As I say, there's no current requirement to mention potential problems if all's well. It is rare, and it's felt that any anxiety would outweigh the benefits. And finally, for those of you who've any interest in this subject at all, there are two papers or two areas I can recommend. One is this nice review by Louise Jones from Barts in Histopathology, looking at everything, the overview of presentation, pathogenesis, guidelines for diagnosis and management. And that's a very well written paper by all the local great and good in breast pathology. And then the information for clinicians and patients on the MRHA site, the gov.uk, provides useful advice. Now, I'm very happy to take questions. I'm very happy to answer written questions. I'm very happy for this talk to be available for you if you would like it. It's a rare condition. Hopefully none of you will ever see it and you'll go through your careers without seeing one, but I thought it was something to be aware of, and this might help give you a helpful overview. Thank you very much.